Hello guys, we will now talk about clinical questions regarding alteration of parathyroid function. So we have a patient 2 hours after admission to the hospital for dialysis. A 63-year-old woman has severe pain in the lower back. The pain is 8 out of 10 in intensity and radiates down the leg. She underwent a laparoscopic cholecystectomy 4 years ago. She has hypertension, chronic kidney disease, type 2 diabetes mellitus, and major depressive disorder. She lives with her daughter and reports frequent fights with her at home. Her current medications include sertraline, insulin, enalapril, sodium bicarbonate, and sevelamer. She appears uncomfortable. Her temperature is 37.3 degrees Celsius and normal. Pulse is 102 per minute, a bit high, but still I would say normal. Respirations 15 per minute, and blood pressure 132/94. So a bit like limit heart rate and blood pressure, but relatively normal. There's severe tenderness and palpation over the L2 vertebra. Range of motion is limited. Neurological examination shows no focal findings. Laboratory studies show. So here we have these values. An X-ray of the spine shows a wedge compression or fracture of the L2 vertebra. So we have like some kind of fracture on the L2 vertebra, which of the following is the most likely explanation for the finding. As we know, that our topic is alteration of parathyroid glands, so we can kind of expect. So what is here like the sign that can show something? So the most important, she has chronic kidney disease. If you remember, chronic kidney disease, was mentioned as an etiology in hyperparathyroidism, because chronic kidney disease, renal tubular damage, leads to decreased reabsorption of calcium. And very important as well, chronic kidney disease, calcium levels very low, so it should be normally, we know that average is between 2.1 2.5 millimoles per liter. In milligram per deciliter, it's between 8.6 and 10. So it's hypocalcemia, as we can see. It's what happens in pathogenesis of chronic kidney disease. As well, we have a bone disease, which can again a sign of hyperparathyroidism, because we have increased PTH, leads to increased bone resorption and bone loss. So therefore, the diagnosis is secondary hyperparathyroidism, because we have hypocalcemia, which leads to increase in parathyroid hormone secretion. And secondary hyperparathyroidism. The second clinical case is a 68-year-old man comes to the physician because of fatigue and muscle cramps for the past 4 weeks. He has also noticed several episodes of tingling in both hands. He has not had fever or nausea. He had a chronic cough for 10 years. He has chronic bronchitis, hypertension, and osteoarthritis of both knees. His father died from lung cancer. Current medication includes salbutamol, ibuprofen, ramipril. He has smoked 1 pack of cigarettes daily for 45 years. He's 175 centimeters tall and weighs 68 kilograms. BMI is 22. His temperature is 36. Normal. Pulse is normal. Blood pressure is normal. While measuring the patient's blood pressure, the physician observes a carpal spasm. Cardiopulmonary examination shows no abnormalities. His hematocrit is 41%. Platelet count. ECG shows sinus with prolonged QT interval, which is the following is the most likely underlying cause of this patient's syndrome. So as we can see, muscle cramps and fatigue, then tingling in both sense of paresthesia and prolonged QT interval. Therefore, we can find, if we would have now, would check for calcium levels, it will probably show us hypocalcemia as well. But in this case, it's due to hypoparathyroidism, so this is the diagnosis.